Good morning. My name is Huey Lin, and with my partner, Dr. Valeria Duarte, we run the Adult Congenital Heart Program here at Houston Methodist. I'm very pleased to be here this morning with Dr. Ryan Yousafzai, who, with Dr. Duarte, are the co-directors of the Adult Congenital Heart Transplant Program here at Houston Methodist. A couple things as far as housekeeping items before we start this morning's grand rounds. We are broadcasting live via live stream and YouTube. The recording is always available for viewing. Consider subscribing to our YouTube channel to get notifications when videos are added. If you'd like to submit a question, text DeBakey, that's D-E-B-A-K-E-Y, to 37607. Our next conference is Cardiovascular Disease Prevention on October 8th. To introduce our speaker this morning, I am truly honored this morning to introduce Dr. Jamil Abulhosn, who started his medical career at UCLA and remarkably has completed all of his training at the same institution. Indeed, he trained with the legendary Perloff child in adult congenital heart disease, subsequently taking over and leading to a predominant position in the field, the Amundsen UCLA Adult Congenital Heart Disease Program. It's now become one of the largest programs in the country, if not the world. He's a leader not only in the adult congenital heart field, but in transcatheter interventions in adult congenital heart disease, spearheading efforts to train the next generation of interventionalists in adult congenital heart disease. Furthermore, he has been an important mentor to a number of leading adult congenital heart disease physicians in the field. Apropos, in 2020, we started our adult congenital heart transplant program here at Houston Methodist, and since then we have completed 14 heart and multi-organ transplants in adult congenital heart disease patients. But our success has relied heavily on not only the tireless efforts of our multidisciplinary team here at Houston Methodist, but the support of our more experienced colleagues from other institutions such as Drs. Stephanie Fuller and Yuli Kim at UPenn, but more relevant for today, Dr. Jamil Abulhosn, Drs. Jeanette Lin, Wei Tan, and Dan Levy, and their partners at the UCLA Congenital Heart Program. We here at Houston Methodist Adult Congenital Heart Program owe an incredible debt of gratitude to the mentorship and guidance of Dr. Abulhosn and his team that they have provided. And so it's appropriate that we invite him today for our DeBakey Heart and Vascular Center Grand Rounds to speak on a programmatic approach to heart and multi-organ transplantation in adult congenital heart disease. Jamil, thank you so much.
Well, thank you so much, Huey, and to your team, Valeria, and everyone down there. And I'm sorry I can't be with you in person, that we're doing this via Zoom. But it's a true honor for me to be invited back to Houston Methodist. And really, I've very much enjoyed over the years working with you and with your team and seeing your program just grow and prosper the way it has. So that's wonderful. And without further ado, I will begin the talk here. And I'm going to talk today about a programmatic approach to transplantation, hopefully successful transplantation for the adult with a failing Fontan circulation. We'll touch on single organ, multi-organ transplant. And really, I'll end the presentation with a case example that I think highlights some of the challenges, difficulties, successes that one faces when dealing with failing Fontan physiology and transplantation. So let's go ahead. So pertinent disclosures, you see them here. I will not be talking about any valvular implants or anything like that that's related to my work with some of the companies that make interventional devices and such. And I will not be disclosing any ABIM examination answers or questions here. So let's just start by talking about single ventricle physiology. What are we talking about here? And really the point is that true single ventricles are actually rare. Most of the time what we're dealing with when we talk about single ventricle physiology is a predominant functional ventricle and a hypoplastic ventricle. And you can see here, so take, for example, the case of somebody with tricuspid atresia that has a hypoplastic right ventricle, but a dominant morphologic left ventricle. True single ventricles are oftentimes a single morphologic left ventricle as opposed to a single morphologic right ventricle. But regardless of what kind of permutation you have here when it comes to single ventricle anatomy, really what we're looking at here are single ventricle physiology patients, meaning that they just don't have a second ventricle that is large enough and functional enough to be used as a pump to either the systemic circuit or the pulmonary circuit. And the operation that revolutionized care for these patients is an operation we call the Fontan Operation. And this is the original publication from 1971. And it was a description of 3 cases by Fontan and Baudet from Bordeaux in France, where they essentially connected the right atrium and the superior vena cava through creative surgical endeavor here to the pulmonary artery circuit directly, leaving the single ventricle as a pump to the systemic circuit and allowing just passive flow into the pulmonary arteries. Now, this is, you may say, well, how would that even work? Well, it works through a couple of mechanisms. One is there's by necessity, the central venous pressure has to be higher, and the pulmonary artery pressure, which will then equal the central venous pressure, has to be higher than the left atrial pressure. Blood has to flow downhill. Can't ask it to flow uphill, especially in a passive circuit, right? The importance of respiratory mechanics here is really key, and specifically the diaphragm being used almost like a plunger. Every time we breathe in and we suck air into our lungs, we are also sucking blood into our pulmonary arteries from the systemic venous circuit. And that in and of itself is a major way in which the Fontan works, is through appropriate respiratory mechanics. And then increased tone, muscular tone in the periphery with venous valves that helps milk blood back to the pulmonary arterial circuit. But you can imagine that any increases in pulmonary arterial resistance, any narrowings within this passive circuit can really cause a problem. Even people living at altitude where oxygen tensions are lower, and so pulmonary arterial resistances tend to be higher, this circuit can fail early. And what we have found with this Fontan circuit is it was so revolutionary in the 1970s, but even as early as the 1970s, and with even this first publication, they said, well, we don't know how long this is going to last, and we don't know what the impact of atrial arrhythmias is going to be. The original Fontan circuits, as you can see here, included the right atrium. And I'll go here and just show you what are the criteria for performing the Fontan operation, or for converting from an older to a newer type of Fontan. But essentially, you have to have single ventricle physiology. It is always better, in my opinion, to try to get a biventricular physiology if you can. So even if you might have a small right ventricle that you don't think is going to take the entire systemic venous load, then one could consider something like a 1.5 ventricle repair, where the superior vena cava is anastomosed to the pulmonary artery. And so that way, in an adult, you're taking away about 30% of systemic venous return to that right ventricle, and then use the right ventricle to just pump IVC blood up to the pulmonary artery. So we always attempt basically to get a biventricular circuit if we can. But if we cannot, and oftentimes we cannot, then we will consider doing these kinds of Fontan type operations. But they require that you have a low pulmonary artery pressure, a low pulmonary arterial resistance, a good single ventricle. If you have a poor single ventricle that doesn't function well, then this is just going to fail from the get-go. And then you don't want a lot of atrioventricular valve regurgitation, or even semilunar valve regurgitation or stenosis on the other side. So you have to have a pretty clean circuit otherwise in order for this to work. And you can't also have restrictive single ventricle physiology. So lots of criteria that are in place for us to even be able to do the Fontan circuit. This is just one of my hobbies is I like to draw and paint and do this kind of stuff and play around with Photoshop. And this is just a representation of the various Fontans through the ages. It's not every single type of Fontan, and I didn't include something called the Bjork type Fontan, which is done in pure tricuspid atresia, where you do have a right ventricle that could be used, because that's really more a biventricular circuit. And I think it's a bit of a misnomer when we call that a Fontan. But be that as it may, these are the main types. Starting in the 1970s until the late 1980s, what was performed is what's called the RA to PA Fontan. And again, there is a tremendous amount of variation to the way surgeons did this, and really just all kinds of creative approaches that people had to doing this. For example, the earliest Fontan that was described by Fontan and Baudet had homograft valves that were placed into the IVC to RA connection and between the right atrial appendage and the pulmonary artery. What they found, though, over time is if you did that, what happened is those valves just kind of froze in the half open, half closed position, and were more a hindrance than a help. And so that was abandoned. And what took over thereafter was a circuit where the right atrium was connected directly to the pulmonary artery. Now, why was that abandoned? The reason that was abandoned and we moved to different kinds of Fontans is if you include the right atrium in this circuit, that by definition has to be a high pressure circuit. You cannot have a Fontan patient is not going to have a normal central venous pressure of 3 or 5 millimeters mercury. Why? Because then their left atrial pressure is going to be 0, and they're going to go into renal failure. They're going to be hypotensive. So what we would consider a normal Fontan pressure in an adult patient is somewhere between, say, 10 and 14 millimeters mercury, which is more than double what your or my central venous pressure is. And these are numbers that we're getting when people are supine and asleep in the cath lab. So those numbers are much higher when we're standing up and walking and running. So by definition, a Fontan patient has a high CVP. And so if the right atrial mass is included in the circuit, the right atrium inevitably dilates, and they start to have lots of arrhythmias and thrombi start to form. So this Fontan was abandoned, and actually many of our Fontan patients, early Fontan patients that had this early type of Fontan, have either been transplanted or converted to one of the newer types of Fontans. And the newer types of Fontans are these two, B and C here. This one is called the lateral tunnel Fontan, and sometimes it's an intracardiac tunnel. And sometimes it's a tunnel that involves the back wall of the right atrium and a prosthetic baffle or a pericardial baffle that essentially takes blood from the inferior vena cava up to the pulmonary artery. And then the superior vena cava is attached to the pulmonary artery, hence a complete cavopulmonary circuit. Oftentimes, surgeons place a fenestration in this kind of Fontan as a pop-off. So now what you're doing is you're trading a lower central venous pressure for some desaturation. And then eventually these fenestrations could be closed with transcatheter techniques or surgical techniques. But this became a much more efficient and less turbulent type of Fontan associated with lower risks of arrhythmias, but surgically a challenging kind of Fontan to do. And in a lot of centers, this lateral tunnel Fontan was thereafter supplanted by the extracardiac conduit Fontan, which is a Gore-Tex tube or a Dacron tube. Typically, it's a ring reinforced Gore-Tex, doesn't collapse in on itself, that is a conduit from the inferior vena cava up to the pulmonary artery and completely excludes any right atrial tissue from the Fontan circuit. So this is how the Fontans have evolved. But regardless of what type of Fontan you have, what we have found is that it's a good fix for a reasonable palliation. Initially, we called it a corrective surgery, but I think we need to correct ourselves here, that these are not corrective surgeries, these are palliations, and palliations that really come with a time limit because, a decade of this, fine, 2 decades, maybe. Once you start to get up above 2 decades of this high central venous pressure and what would be a considered low cardiac output state just from one having a Fontan like this without proper augmentation of cardiac output with exercise, what ends up happening is over time, the organs start to suffer. And specifically, we're going to focus on the liver because that is really what we're dealing with now in our older Fontan patients in their 4th and 5th decades of life. And even in some starting earlier than that, where they are now having not just heart failure, but multi-organ failure, including liver cirrhosis and liver failure. So Fontan failure is really a multi-system disorder. So it makes sense, right? You have an increased central venous pressure. It's really the sort of the best, purest model of pure right heart failure, where you just don't have a right ventricle and your central venous pressure is always really high. And what does that lead to? That leads to liver congestion, no brainer, which leads to portal hypertension, which leads to splenomegaly, which leads to portosystemic shunts, which leads to also mesenteric edema. And so therefore there's malabsorption. There is increased chronic pressure in the venous system that leads to failure of the venous valves throughout, especially in the lower extremities. And so you end up with these huge varicose veins and lower extremity edema and so on and so forth. So, many of the consequences are related to this high central venous pressure, and the rate of liver failure, or the almost every Fontan patient you look at is going to have, if you image their liver, it's not going to be normal. It's going to be enlarged, it's going to be congested. Non-invasive imaging is oftentimes going to say that they are cirrhotic. Most of them may not be truly cirrhotic in the same way. It's not a sort of an inflammatory cirrhosis that you see with hepatitis, for example, but it's the kind of bridging fibrosis that develops with this chronic congestive process. Could it be reversible? We think that it might be in some patients, but the reality of it is the risk of just doing a heart transplant alone and hoping that the liver is going to improve may not be worth it. And I'll show you some data on that in a moment. So how do we define Fontan-associated liver disease? And this is from a nice publication last year by Al-Said from Cincinnati Children's that was looking really for reaching a consensus for unified medical language when it comes to Fontan care. And here's the definition: the broad spectrum of liver disease and its consequences attributable to Fontan hemodynamics. FALD, Fontan-associated liver disease, includes varying degrees of hepatic fibrosis, compensated or decompensated cirrhosis, focal nodular hyperplasia, very, very common when you image these patients by MRI, laboratory evidence of hepatic injury, often with elevated bilirubin levels, or impaired synthetic function, typically a late manifestation of this. And then really very, very concerning is hepatocellular neoplastic lesions, hepatocellular carcinoma, which is occurring, we think, in somewhere between 1% and 4% of our Fontan patients. And so it's something that we are constantly screening for at our center. What we do is ultrasounds of the livers every 6 months on all of our adult Fontan patients, looking for any lesions that then we work up and try to address very early on, because really liver transplantation can be curative in these patients, even if they have these neoplastic lesions, if they're discovered early. So, something that we spend a lot of time looking for and making sure that we're not missing. Because we have had some disasters where these things have been missed and for years and then become inoperable in our patients. Let's just go over a score here called the VAS score, and this is from our colleagues at Emory. And this is a score that essentially attempts to identify just how much of a liver problem the patient may have, looking at some imaging and some lab findings. So you get a point for each of these. If you have varices, and these are esophageal varices. Remember, these patients inevitably have portal hypertension. So if you have esophageal varices, that's reflective of a more advanced process and higher resistance to flow within the liver. Ascites, makes sense, splenomegaly, and thrombocytopenia, which is often associated with splenomegaly, of course. This is a consumptive process related to splenomegaly. You can look at the risks of transplantation, hepatocellular carcinoma, death, and you can see that those with a VAS score greater than or equal to 2 are much more likely to have complications when compared to those that have a low VAS score. And so already we're seeing that the liver is playing a major part in the outcomes of these Fontan patients. This is from a publication last year from our group that's really kind of a, and I would say that this is not a bad sort of playbook to have as to just, and it's just the way we do things at our institution, but we basically go through from A to Z how we address Fontan patients who we are putting through the transplant process, from screening all the way through to performing the operation and then follow up thereafter. You know, and obviously this will be adjusted by various other centers and hopefully will evolve and get better over time, but we wanted to put it out there. And so I would recommend much of what I'm saying today is in that document. So the hemodynamic characteristics of Fontan failure, I really put them into basically 3 categories here. So a Fontan that's failing with a reduced single ventricle ejection fraction, where the ventricular end diastolic pressure is often elevated, the cardiac output is low, the systemic arterial resistance is high, right? This is acting like a heart failure patient. And the pulmonary arterial resistance in these patients would be considered normal for you know, an adult patient. Now, there is a caveat to this, that the pulmonary arterial resistance in a Fontan patient plays so much more of a role in affecting Fontan function that even mild or upper limit pulmonary arterial resistances, where we wouldn't, you know, a PH group would look at this and go, oh, well, you know, the pulmonary arterial resistance here is only 2.8 Woods units times meters squared. We would consider that in the, you know, upper normal range. Well, that would be elevated for a Fontan patient. And so this is beyond the scope of this particular talk, but really treating patients to lower that pulmonary arterial resistance is key in this population to reduce that Fontan failure rate. The second category, failing Fontan patients with normal single ventricle systolic function, where the end diastolic pressure here may not be elevated and could even be low. The cardiac output, however, would still be low. Why? Because this is more of a preload issue. Here, the SVR can be normal or high, but here the pulmonary arterial resistance can be elevated. And so this is, for example, a Fontan patient that is living at high altitude, and they're swollen up in their edematous, but their single ventricle looks like it's working fine. And this is a problem within the Fontan circuit itself, a pulmonary arterial resistance problem. Or another example of this would be a Fontan patient that has stenosis of a branched pulmonary artery. And so therefore, there's an elevation in the Fontan pressures, but the single ventricle pressures, filling pressures are normal and the single ventricle function is normal. And then the last type, which is really unfortunately the type that a lot of us are seeing and kind of the end stage type, is the Fontan patient that now has a liver that's failing. And so now not only are you dealing with Fontan physiology and all of the perturbations thereof, but now you're dealing with, on top of it, the cirrhotic physiology, which is now a high cardiac output state, right? So, and a low SVR state. So in this particular case, systolic function of the single ventricle can be normal or reduced. The ventricular end diastolic pressure is high though, because again, they have liver failure. And think about now, forget the Fontans for a second, think about the liver failure patients that you have who have biventricular anatomy. right? And oftentimes they have very elevated CVPs, high left atrial pressures. So this is what's happening here as well. The cardiac output here may be normal or even high. The systemic arterial resistance here may actually be low, especially if the liver is really done. Then you may be dealing with a systemic arterial resistance here of only 3 or 4 Woods units. And so just pumping these patients full of pulmonary vasodilators and milrinone may actually put them into renal failure, and they may do worse. So this is where cardiac catheterization plays a really key role in Fontan patients. You know, we say diagnostic cardiac catheterization is a dying art here, right? That everything can be figured out non-invasively. You know, you only go to the cath lab to do an intervention. Well, not here. Here, you've got to actually do a proper cath and a proper congenital cath, and you've got to figure out the systemic arterial resistance in these patients early in their sort of transplant workup course, because if you're going to bring them in and put them on pressors, then you want to put them on the right pressor. So oftentimes for our patients that have reached this level of Fontan failure, we are putting them on a combination of pressors that also includes something that increases afterload. So now they're being treated almost like a liver failure patient, right? You know, with the addition of things like vasopressin, or putting them on midodrine, just really trying to raise that SVR to perfuse the kidneys. So anyway, just a few examples here, the major grab bags that we have of Fontan failures. So now let's talk a little bit about survival after, and this is just after OHT and not looking at liver transplantation. And it's a bit dated here. This is from Luke Burchell, 2014, looking at ACHD versus non-ACHD transplantations. And what you see here is the long-term survival of an ACHD transplant patient is actually potentially a little bit better than a non-ACHD transplant patient, but you're not going to see that until many years after the transplantation, because initially the survival is worse. Why? Because we're dealing with really complex anatomy. We're dealing with patients that have had, you know, multiple sternotomies and thoracotomies, and they've had blood transfusions. They may have homograft tissues, so they're highly sensitized. You know, so you are dealing with some issues early on that, if they can survive this early period over the first really year after transplantation, then their longer term outcomes are not worse than other people. So this idea that, oh, ACHD and congenital transplants are going to sink your transplant program is, I think, a fallacy. Why? Because it really is, can you get them through the early part? If you can get them through the early part, they'll do well. They will do better than if you cannot get them through the early part. And then obviously you're taking a big hit. So this is where the onus is upon us and our surgical teams to ensure that we get them through the transplant and through that first post-transplant year. And that's a lot of what I'm going to focus on today, is how at UCLA we have approached that particular issue. And if you look here at figure B, survival in those that have survived the first year of transplant is, again, much better in the ACHD population than in the non-ACHD population. These patients are often younger as well. So that's the other thing they have going for them, right? We're not talking about, you know, 68 years old. We're talking, you know, a patient who's maybe in their 40s. So that's an advantage as well to the ACHD patients. Now, again, this is a bit of a dated study here, but if you look at Fontan versus non-Fontan patients and the long-term outcomes, certainly Fontan patients are worse than non-Fontan patients. And if you look here at the relative risk of, in a multivariable analysis of mortality, you'll see that in the early phase here, in the first year, having a previous Fontan is the highest risk factor here, 8.6 relative risk versus, you know, and also if you've had a Glenn here in the constant phase, which is a part of many Fontan patients, that does continue to also be a risk factor. So certainly, you know, the highest mountain to climb of all the congenitals and the most difficult transplants are going to be the Fontan transplants. How about effects of center volume on outcomes? And this isn't specific to Fontan's, but to ACHD transplants in general. This is work from the group at the University of Washington that was published in 2019. And what it shows here is that the number of congenital heart disease patients listed for transplantation has increased year by year. And I would say that this number, if we look now, is going to be even higher as well. And if you look here, the vast majority of these patients are listed at adult hospitals, not at children's hospitals, which makes sense because many of the Fontan patients that are in their fourth and fifth decades of life have made the transition from a pediatric to an adult practice and typically are being seen at adult hospitals. And if you look at the number of CHD patients that are actually transplanted, again, the numbers are higher at adult hospitals than at pediatric hospitals. Now, if you look at the predictors of wait time or wait list mortality, who is surviving and who is dying before they get the transplantation, turns out that center volume doesn't have a huge impact here, but and this is the first data to show that ACHA comprehensive center accreditation actually makes a difference as far as outcomes. And if you look at the waitlist mortality between those that are being taken care of at accredited centers, and what does that mean if you're an accredited center? It means you have all the bells and whistles and the staffing and the processes to provide comprehensive care to adult congenital patients. Listen, anybody can take care of a patient who has an atrial septal defect, right? And that's fine. You can, maybe Huey closes the ASD, but that patient can be followed over time in any practice and can come back and see Huey every year or two, and that should be sufficient. But a Fontan patient is a completely different animal, right? That's a multi-system disorder, lots of moving pieces, lots of balls in the air. So this is where it makes a difference if you actually have a program like you guys have at Methodist, which takes excellent care of these patients and addresses all of their issues. And so therefore, they can actually survive until transplantation. If you look at pediatric versus adult transplant centers, this is where it's really key to actually have expertise in congenital heart disease. And I think this is where, what I would take from this data is to say pure adult transplant centers, if they want to get into the Fontan transplant game here, they've really got to ensure that they have the appropriate ACHD setup to take the best care of these patients possible while they're waiting for the transplantation. This is data from the Foster study, and this is Foster 2 that is as of yet unpublished, but I have the permission of Matt Lewis, who's the PI of this multi-center effort, to show this data. So thank you, Matt, for that, and thank you for what you're doing, bringing us all together to give you this data, and we all contribute, or at least we contribute to this data as well. But it's looking at Fontan outcome study to improve transplant experience and results, and it's an international collaboration whose mission is to improve transplant outcomes for adult Fontan patients. And so let's look here at heart versus heart liver transplant, okay? And if you look at here in blue is the combined heart and liver transplant, and in dashed red is just heart transplantation alone, and cumulative incidence here of survival. So this is, if you're higher up here, you're better. So if you do a combined heart and liver transplantation on a Fontan patient, it looks like they actually have better survival than if you do heart transplantation alone. Now, there's some caveats to this. This is not the message that I want to leave you with. But if you just superficially look at this, you'd go, oh, well, every Fontan patient should get a heart and liver transplantation. I don't believe that that's actually the case, but certainly we should consider heart and liver transplantation and know how to do heart and liver transplantation in any Fontan patient when we're actually looking at them for transplant candidacy. So this is looking at the combined heart and liver transplant versus heart transplant outcomes. after the year 2000. So it's only fair to look at this in a more current era than to go back and look at those heart transplants that were done in the 80s and the 90s on these Fontan patients when there was still a big learning curve. But even in the current era, you're seeing a separation of the curves, although at this point it's not statistically significant. But certainly I think, if we were to follow this out, you would find that there's a separation as well here, but not as convincing and not as statistically significant. Now, if you add something called the FALD score, and the FALD score is basically the VAST score, except what Matt here did is replaced ascites with greater than or equal to 2 paracenteses. Why? He was getting all this data from all these centers, and it was unclear, if patients had true ascites or not or whatever. So set the threshold at did they need a paracentesis and did they need 2 or more paracenteses? And then that's really legit there. That means you really are having ascites and large volume ascites if you've had to have 2 paracenteses. But he assigned 1 point for each of these findings: cirrhosis, varices, splenomegaly, greater than or equal to 2 paracenteses. And if you had a FALD score that was 2 or greater, then you're far better off getting a combined heart and liver transplantation than just a heart transplantation alone. Excuse me. So simplistically, when you're evaluating a patient who has a Fontan for transplant, get imaging. If they have varices and they've got splenomegaly, then you should consider a heart and liver transplant. And that's what we would do here at our center. Now, we do liver biopsies on all these patients, and we look for cirrhosis and such, and certainly if they've had paracenteses. But even just, a CTA of the chest that shows you varices and splenomegaly, chest, abdomen, shows you splenomegaly and varices, pushes you in the direction of a heart and liver transplantation versus a heart transplant alone. And then if you look at cumulative survival rates by FALD score, this is regardless of what kind of transplant they got, it really is very predictive as well. So, essentially a lot of what happens to our Fontan patients is going to be driven by what happens to their livers. So now let's go through a case example. And through this case example, this is a gentleman named Skylar Collins, and I have his permission to use his name and use his picture here. And I think his story is really a story of a Fontan, an adult Fontan, and all of the issues that one goes through, even at a high volume transplant center. So let's start with his case example. And through his case example, I'm going to also show you the way we approach the Fontan patient and what we do at our center from a programmatic standpoint to try and get good results in these patients. So here we go. He got to us when he was 27, but he was born with a hypoplastic right ventricle, so not true single ventricle physiology, but a small right ventricle and dominant left ventricle. He had an intact septum, pulmonary valve atresia, and discontinuous pulmonary arteries. So basically the right side of his heart had not grown properly, and his pulmonary arteries did not develop properly either. At 3 days of age, he undergoes a modified right Blalock-Taussig Thomas shunt. At 7 months of age, so that's a thoracotomy on the right at 3. At 7 months of age, he undergoes a right classic Glenn shunt with a BTT takedown and then ligation of the azygous vein and the left SVC. So now he gets a sternotomy for that at 7 months of age. At 2.5 years of age, he gets another sternotomy. He gets a central shunt to the left pulmonary artery. At 8 years of age, he goes through another surgery with yet another sternotomy, a shunt takedown, LPA reconstruction, new central shunt to the LPA. Now, can you imagine presenting this stuff to an adult transplant group that has no or little experience with congenital heart disease? But at this point, most people want to run for the hills when they're hearing this story and going, wait. And transplant surgeons are looking at this going, whoa, no, this is too much. So this is where developing a team that has the knowledge and the expertise specifically in the care of these kinds of patients is absolutely key. And that has been something that has taken a while to do, but we're on our way to that. At 9 years of age, again, another sternotomy, this time an LPA takedown, a connection from the LPA to RPA with a 12 millimeter Gore-Tex tube, patch augmentation of the LPA branches with a homograft. Now, we're homograft tissue is being introduced here. So now we got to think about antibodies and sensitization. And then another modified left Blalock-Taussig shunt. And then at 10 years of age, he eventually has a Fontan, and they put in a 16 millimeter, which nowadays we know is too small. You want to try to put in a 20 millimeter Fontan, but he gets a 16 millimeter fenestrated extracardiac conduit and takedown of the BT shunt at that point. And that's just his surgical history. How about interventional history? 9 years of age, gets coil embolization of AP collaterals. At 17 years of age, Fontan fenestration closure. At 24 years of age, stenting of the extracardiac Fontan, embolization of veno-venous collaterals. At 26 years of age, and this is, he came to us from Washington State, where he lives in Spokane, or lived in Spokane, Washington. And so he was referred to us from Spokane for consideration of OHD and OLT. You know, after going through everything, we decided that we would accept him for listing. He had been turned down by multiple other programs that were much closer to his home because of the surgical risk, given all the surgeries that he had had and decompensated liver failure as well at that point. He had with us further stenting of the extracardiac conduit, which was kinked and very narrowed. And then we began coiling off further collaterals, and this is an expectation of transplantation. And this is a strategy that we have that's very different than the strategy we have in a patient who's not being considered for transplantation, where we are typically not touching veno-venous collaterals because we want those to be in place as pop-offs to not allow the Fontan pressures to be too high. But once we decide that we're going to actually go forward with a heart or a heart and liver transplantation, our strategy changes, where now we want to just knock all potential bleeders out of the chest. And I will spend hours and hours and hours, multiple visits to the cath lab, essentially coiling and plugging every vascular collateral so that when the surgeons go in, they're not dealing with a bloodbath. Because remember, what happens to these patients is there's a 30% mortality rate in that first year, and much of that is the intraoperative and immediate perioperative mortality, and much of it is driven by uncontrolled bleeding. So a strategy to try and now mitigate the bleeding risk. And this is where, again, working hand in glove with our surgical team to essentially optimize the landscape for them so that they can go in and try to do the surgery as safely as possible. This is our ACHG transplant evaluation checklist. This is what we send to other programs and referrings. If they want us to consider a patient for transplant, we want all of this data, okay? And that includes, you notice we've bold typed there the images, right? We want the not just reports, but the CT images, the echo images, the MRI images, and so on and so forth. And all of that is sent in, and then we put all of that together, and then we review the patient. And I have to stop here for a second and give, you know, a lion's share of the credit to my partner, Dr. Jeanette Lin, here at UCLA. I don't think she gets enough credit for the work that she does here, which is to keep us organized and keep us on track with all of this. It really takes an orchestra conductor, because this is what this is. It's an orchestra, and you have to have somebody who's putting all of this together and conducting appropriately. And so Dr. Lin does that for us. And you know, at various programs, you may have different setups where different people are kind of in charge of all of this, but at our program, we have decided that the adult congenital heart disease team is the most invested in these patients, knows them the longest, and so we've decided to take that on. Now, it's an immense amount of work for our faculty, for our nurses, our NPs, etc. And you know, you'd love to have institutional support for these kinds of things, but don't hold your breath for it. You may just have to do it yourself and get it done and hope that somebody decides that it's worthwhile to actually invest in it. But this is the checklist that we ask for when we're evaluating these patients. And I believe I've shared this with, or we've shared this with Huey and Valeria, but something along these lines is necessary. And it's a multidisciplinary team approach. So, I mean, just look at the number of teams and specialties that have to be involved in a single Fontan transplantation. And again, this is that publication that I told you about. That's our playbook. All of the stuff that I'm going over, much of it is in this publication. So you have to identify teams and specialties that are stakeholders. You have to identify point persons, leaders of each team. So, you know, nowadays, like there's this whole thing where everybody's talking about teams and teams of teams and the team approach and team. Team's great, right? Hey, I love teams. But here's the problem. There needs to be personal ownership. So you can't then go, okay, who reviewed this? And they go, oh, somebody from the heart transplant team. Well, who? Who is that person? So let's actually have individuals that are stakeholders that take responsibility for their jobs and that are the sort of leads of each of these groups. And if you don't have that in place, then I have found that the buck gets passed around a lot. And so I really would say, you know, identify point persons and leaders of each team that are going to be involved in this process. Central coordination is key. For us, it's by the ACHD team that's quarterbacking this entire process. And I, again, mentioned Dr. Lin and her very important role in this, okay, which I would say, you know, one should have someone like that at every institution. And it should not, and it can't just be somebody who's at the nursing level or a nursing coordinator level or even an NP level. I would say that this kind of role is a physician role. This is, we are talking here about trying to corral a bunch of physicians from various teams and such. And I think this is where having somebody at the physician level doing it is going to be much, much more effective. Fontan transplant case presentations and discussions. So we have one, for example, this afternoon where we will spend literally 2 hours. And we used to do it in person. Now it's done via Zoom, reviewing patients. And sometimes each patient takes an hour, and we have the various stakeholders all on the line, including the liver transplant surgeons, going through the imaging, including the ICU folks, including the anesthesiologists, going through everything and deciding how are we going to play this in a very, very honest and forthright way. Ensure that all patients are comprehensively reviewed and discussed prior to presentation to the adult transplant committees. What I found is that if you don't get all your ducks in a row on the ACHD side and do all this homework before you go to the adult transplant committee, good luck. You're going to go to the adult transplant committee. They're going to look at all this stuff. Everybody's going to be confused. You're going to lose them by the time you're talking about the third surgery that the patient's had. And then they're going to look at you and go, well, you know what? We're not willing to take such a high-risk transplant on. On the other hand, if you have all of your ducks in a row, you have your transplant surgeons in agreement. And the model we have at UCLA is that our congenital surgeons are also our transplant surgeons for the complex ACHD patients. So, you know, Glenn Van Arsdale, when he was looking to come to UCLA from Toronto, met with me and I said to him, I said, you know, the main thing I want you to end up doing here is Fontan transplants as well. And he looked at me and said, well, I'm not a transplant surgeon. And I said, well, you know, at UCLA, I think you're going to have to be, because this is what we're dealing with our Fontan patients. These are people are hitting a certain age and falling off a cliff, and we're not going to just sit here and watch them fall off a cliff. And so, to his credit, he took that very seriously and really, you know, changed gears in many ways and became fantastic at doing this. And now we have Ming Sing C as well, Dr. C and Dr. Pinwali, and we've, you know, so you have to build that kind of surgical expertise, but get all your ducks in a row before you take it to the adult transplant team. That's a lesson that I have learned the hard way over the past 2 decades. And then comprehensive review and planning is key. So this is just a diagram that shows all of the anatomic issues that one has to deal with in a Fontan patient who actually has levocardia here. Now, if you had dextrocardia, that'd be a different story. But this patient does have abdominal situs inversus. But you have to review all the imaging data. You have to consider and discuss mechanical support and other non-transplant alternatives, because there may be things that we can do that don't require transplantation, such as stenting the Fontan, for example. Or in one case, I remember she had such copious arteriopulmonary collaterals and was so severely overcirculated that really the approach was knocking out all of those AP collaterals over multiple visits. And after we did all of that, she felt a lot better. The Fontan hemodynamics improved immensely. The severe AV valve regurgitation became mild, and we didn't need to transplant that young woman. And that was years ago. And she's gone about her business. Now, eventually she'll come to us for transplant, but we were able to push it off by doing these other things as well. Now, admittedly, we have not done a ton of mechanical support in our Fontan patients, and I think that there's an opportunity there for teams and possibly those in Texas like you guys to really push this field forward with mechanical support of these Fontan patients. And then determination regarding need for multi-organ transplantation, and this is where having the liver team, the kidney team, the lung team, and so on present is key. Surgical plan, we go over the surgical plan in great detail. Where are you going to cut? What are you going to do? What are you going to put here? Who's going to do what? It's just including listing parameters, what size of patient we're willing to take, age, distance, so on and so forth. And then the need for interventional preparation, which again is a big part of what we do, is prepare the patient for the surgery by doing some of these other interventional things that I talked to you about, such as coiling. So all patients at UCLA that are undergoing the process to be considered for transplant will undergo a cardiac catheterization. We do upper endoscopy, and we do a liver biopsy. And the liver biopsy is done at the time of transplantation and is transjugular. Rarely we'll do liver biopsy from below via the IVC. And very, very rarely a transcutaneous liver biopsy. The endoscopy and the liver biopsy are used to better evaluate patients and determine the level of liver dysfunction beyond just simple laboratory evaluation, since many patients will have preserved synthetic function while still having significant fibrosis or cirrhosis. If the patient has biopsy-proven cirrhosis, as evidenced by extensive bridging fibrosis, then we uniformly will recommend a combined heart and liver transplant. Furthermore, our current practice is that patients with significant bridging fibrosis and stigmata of liver disease with varices and splenomegaly are just referred for combined heart and liver transplant. So there are certain centers, for example, at Penn, my understanding is they've stopped doing liver biopsies now and are just using the imaging data. And maybe eventually we'll move in that direction. But at this point, since we're cathing the patients, we're doing the liver biopsy anyway. And then each patient is assigned a VAST score, or you could assign them a FALD score, either or, I think could be interchangeable here. And if the number is 2 or greater, then we're sending them for liver transplantation as well as heart transplantation. As far as the collateral coiling, this is data from when Wei Tan was with us doing his fellowship and then ACHD interventional fellowship, where we looked at all these patients that had gone through transplant and basically found that the bleeding is better controlled if we're knocking out all of these arterial collaterals and venous collaterals in the chest, so that the surgeons, when they go in, are not dealing with all of this bleeding that cannot be controlled because of collaterals. It doesn't mean that they're not going to bleed, because obviously there's medical reasons that they're going to bleed, and then there's issues when, if you injure the lung or injure any other tissues or get into the aorta, obviously they're going to bleed. But at least this helps to reduce the blood transfusion needs of these patients. Now, this is from the Mayo Clinic, showing, as far as veno-venous collaterals, that if patients have elevated Fontan pressures, 14 millimeters mercury or greater, you're better off not knocking out venous collaterals. And this is where I've gotten a lot of pushback when I've talked about this embolization strategy that we have, where people go, well, hold on a second. If you're knocking out venous collaterals, you're raising the Fontan pressures potentially. And we know that based on this data, the long-term outcomes are worse if you knock out venous collaterals. And my answer to that is, that's true if we are not committing the patient to transplant. But once we've actually accepted the patient for either a heart or a heart-liver transplant, the game now has changed. Our gears have changed. Our goals have changed. Now our goals are to get them to survive the transplant, not to get them to survive with a Fontan for the next, 10 years. And oftentimes we're changing also the hemodynamic milieu by bringing them into the hospital when we list them, putting them on inotropes and chronotropes, and putting them on intravenous diuretics, and really trying to, our strategy with these patients is we don't list them as outpatients. We bring them in and we put them typically on a combination of milrinone and vasopressin and some intravenous Lasix or Bumex, and we basically keep them in-house waiting for the organs to be available. And during that time, we have them exercise daily. We put exercise bikes in their rooms, and we have nutrition see them. So we're basically trying to fatten them up and get them into the best shape possible so that when they're going through the transplant, they are optimized. They're not volume overloaded. They don't have ascites. Their muscle tone is good. Their nutrition is good, and all of that. So this kind of data doesn't really apply to what we're doing when we've decided to go forward with transplant. But it's worth knowing that if you see venous collaterals in a patient that you don't intend on transplanting and they have a Fontan pressure that is elevated or borderline elevated, leave those collaterals be. You're better off not knocking them out unless there's some really good reason to do so, like, for example, paradoxical emboli. This is an example of our ACHD transplant surgical planning meeting. And this is for Schuyler specifically. And if you look, all kinds of data is in here: blood type, what distance we're willing to accept, the age of the donors, the height, the weight. We want to try to, we don't want hepatitis C positive donors here. Vascular access. We've gone through and imaged everything. Why? Because we want to be prepared for ECMO. We want to be prepared for going on CRRT. And nowadays, we're oftentimes cannulating patients ahead of time, just saying we are going to almost certainly go on CRRT in the OR, or we are not going to come off on rocket fuel here and send them upstairs on 5 different pressors. We'd rather send them up on ECMO and give them a little break so that we're not now damaging other organs in that early postoperative period. But lots and lots and lots of data that is being discussed here, real minutia. We don't have to go through all of it, but just gives you an idea of the kind of attention to detail that this takes. And again, credit to Dr. Lin for putting this in place for us and really bringing us all together and herding cats. That's what she's doing. This is the UNOS guidance for exception requests. And if you think about it, most of our ACHD patients can be 3E, but for our Fontan patients, we're often able to get them a 2E exception. Why? Because we often have to have them on multiple pressors, or they cannot tolerate pressors because they're having arrhythmias, for example. One thing we've been bitten by that I would just give you a word of caution about is these patients sometimes spend months in-house waiting to get organs. And so we end up putting PICC lines in them for easier blood draws to give them the inotropes and chronotropes. And so we were putting them on heparin. And we've had a number of bleeds now that some have been peripheral bleeds, but we've also had intracranial bleeds. So that one, we're still trying to figure out what the best strategy is as far as anticoagulation while they're waiting. And we're moving away from keeping people on just IV heparin just given the complications that we've had with that. But what we're doing is with each case, we're learning. Then on the day of the transplant, another team huddle takes place, because sometimes these people have been in-house for months and people may not remember all of the exact details. So what we do is basically sit down and go over with anesthesia and with surgery all of the different aspects of the case and what we're going to do that day, and who's going to do what. Like Glenn here, this Glenn Van Arsdale, surgeon, needs 2 hours of operative time on the front end. Continuing to have issues with hypothermia with HD. So what are we going to do about that? Need for appropriate volume. We're going to use a warm dialysate, and so on and so forth. Little things like, Emily and Lorraine need to speak with the cardiac team. I mean, this is, you're probably going like, well, why does this belong in a grand round stock? The reason it belongs here is that this is what it takes. This is literally what it takes. And who's quarterbacking all of this? Again, the ACHD team is quarterbacking all of this. Now, it doesn't have to be the ACHD team at your institution, but somebody who's a stakeholder has to quarterback this. If you don't do this, you're going to run into trouble. So the long and winding road to transplantation for Skylar. So in July 2019, he comes to UCLA for OHD evaluation. He has edema, poor exercise tolerance, the guy's volume overloaded. We say, oh, he's acceptable for listing. So he was accepted with a plan for admission with repeat cath, and this was delayed because of the coronavirus pandemic. So now we've pushed that from March to July of 2020, and he's admitted for elective cath and listing for heart liver transplant. He has multiple AP collaterals, and we coiled those off over the course of 3 different catheterization procedures. And I'll just stop there to say, and specifically this is to Huey, my limits are, I don't want to give more than 250 cc's of contrast per visit to the cath lab, and I don't want to go over 40 minutes of fluoro each time. So I don't want to cause radiation burns. I don't want to knock out the kidneys. And so if I can't take care of all the collaterals in the span of that kind of time and with that kind of contrast load, then I give them a break. They come back a couple of days or a week later. We do it again. If we need to do more, we bring them back again. We do it again, and we don't list them until we know that we've knocked out all the collaterals. He was listed as status 2E because he was unable to tolerate inotropes because he kept going into arrhythmias. He was otherwise largely stable during the hospitalization for the next 3 months until October, when he was switched to status 7 due to lack of surgical availability. And again, I have, Dr. Van Arsdale's permission to speak about this, but there was a physician illness that took place at this time. And so therefore, what lesson is learned from there? What's learned from there is you have to have a deep bench. It doesn't matter if you've got Lionel Messi as, your starting surgeon. Lionel Messi breaks his ankle, and if you have nobody on the bench that can replace him, or whoever's on the bench to replace him is not capable of doing that level of surgery, then you might as well just shut it down. So this is where we've tried to address it now by bringing on other surgeons that are also doing this. So this is where you've got to have duplication of roles and quality duplication of those roles. So, and I'm being very frankly honest about this because I want other people to know what our experiences have been and what we've learned from this and what we've had to do to correct these problems. So get yourself a deep bench because things happen to people. So he was discharged at this point. He'd been relatively stable during this time, pending surgical availability. And then he goes back up to Spokane, and he spends, almost a year up there, followed closely via telehealth. This is Dr. Lee Reardon, another member of our team who also deserves a ton of credit. On a weekly basis, he was on telehealth with this young man and checking on him and making sure that he remained dry and taken good care of. And this is another really shout out to also a regional national model for ACHD care. And specifically when it comes to, working with colleagues locally. Eventually returns to Los Angeles, and now has new collaterals that we had to get rid of, and then gets delisted again. Why? Because we had some mortalities, and now the program was like, oh, this is too high risk. So again, you're dealing not just with what's on the ground from the ACHD side, but the background issues of the larger transplant program. But eventually he comes back in, gets relisted, and then goes through his transplant. And one thing that I would, and I know I'm running short of time here, but I just want to say that every time you have an outcome, whether it's a positive or a negative outcome in a patient, you have to have regular case reviews, quality improvement efforts. They've got to be thoroughly and honestly discussed, and plans made for how you're going to change things in order to get the best outcomes possible. So then he goes to the transplant earlier this year. Huge surgery with reconstruction of all kinds of things, but it all looked good at the end, but had to be on hemodialysis to combat lactic acidosis. There was some mechanical lung injury. There was severe hemorrhagic shock related to that, diffuse bleeding within the chest. Despite all of our coiling efforts, over 60 units of blood products used, eventually transferred to ICU. Graft is working well, though. Liver function was acceptable, and really does very well and gets discharged about a month later. Has not been readmitted with heart failure, initially required some oxygen, but 1 month post-discharge had excellent hemodynamics on cath, and this is Skylar outside of the hospital and now walking around and a much happier person. But look at the journey it took for him to get there. Philanthropy is absolutely key. Listen, I wish institutions supported these kinds of efforts to the point where we can cover everything through institutional support. But unfortunately, that is not the case oftentimes. And so this is Delphine Lee, who is the mother of a Fontan patient who had a transplant with us and was appreciative for all the care that her daughter received, and actually gave an endowed chair in liver transplantation to Dr. Fadi Kaldas, who's our liver transplant surgeon that works with us for these Fontan patients. So really, again, stakeholders, bringing somebody in. So now this is his passion as well, not just ours, but his as well. And once you bring that in and you build this team and you make people stakeholders, you're going to get better outcomes and more commitment. So in conclusion, building a Fontan transplant program requires the coordinated interplay of multiple stakeholders. A team of teams concept is necessary, but personal ownership and responsibility by individual team members is absolutely essential. You can't get around that. At UCLA, the ACHD team plays a central role in the coordination of the program. Regardless of which team plays the role at your institution, someone needs to take ownership of the organizational aspects of the program, and then ensure that stakeholders are invested in the Fontan transplant program and seek institutional and philanthropic support for the program. Philanthropic support is really, really key here. And there's nobody that's more appreciative than patients and their families. And then regular performance review with the goal of blameless, yet very critical review with an eye for making improvements and testing hypotheses is really important as well. So I thank you. And really, this wouldn't happen without all of these people. So it really takes a village. Thank you so much. And I'm sorry I went over a little bit.
Well, thank you, Dr. Abelhausen. That was really an incredibly tour de force. I'm actually going to turn it over to Dr. Yousafzai to moderate some questions. We have a ton of questions that have come in online, but we have limited time. So, Dr. Yousafzai.
Thank you. So, thank you, Dr. Abelhausen, to be here. It was amazing, amazing talk, very eye-opening. As Dr. Lin said, a lot of questions. I'm going to try to pick a few questions, especially mostly in the level of the programmatic and society level. There's a question comes from Arvind Brimraj, our interim heart failure chief. He is suggesting, as you mentioned, the importance of having a dedicated, person to take care of this ACHD patients in each specialty. He's asking about creating an ACHD certification for advanced heart failure cardiologists so they can work, so they become more ACHD savvy, so to provide the appropriate care for this ACHD patient. He's asking, would you think the society would support that? And what are your thoughts about this concept?
I think it's actually a great idea, and I think that a certain level of training and education is necessary for anyone who's going to be involved in this population, in the care of this population. I mean, in an ideal setting, what I would say is to actually have and identify somebody who goes through an ACHD fellowship, the full 2-year ACHD fellowship, and a 1-year heart failure / transplant fellowship. And that person is now ACHD board certified, knows all the bells and whistles as far as ACHD, and also has the training for heart failure and transplant care. I think that would be the absolute ideal. And I think that's something that we should identify people that want to do that and have training pathways that are available. In the absence of that, I would say some sort of curriculum in place that allows for a certain amount of didactic learning. Because listen, in the end, it's learning a new language. If you come from, I come from the adult cardiology world and the adult medicine world, and you know, when I did congenital, I literally had to learn a completely new language and a new history of all of these things, and that's not going to come overnight. So I would say the ideal is to put them through an ACHD fellowship pathway. That would be my answer.
Thank you. And about the Fontan and heart and liver transplant, there's a question coming that, you know, you mentioned obviously the need for this, how to identify a patient who needs a liver transplant. And as we know, a lot of these patients, they come with some liver dysfunction. The question is, what criteria do you banking on to not to do liver transplant, and you still know this patient will do well after heart-only transplant, these Fontan patients?
Yeah, so if they don't have splenomegaly, if they don't have varices, if they don't have any of the stigmata of liver failure, if they don't have liver cirrhosis, then I would say just do a heart alone in those patients. But I think if they have any of those other things, then I would consider combined heart and liver transplant. And that's why I showed that Foster data from Matt Lewis, which is, you know, I think it's pretty clear that if they have those stigmata, that they're going to do better with a heart and liver transplantation. So, you know, the other question is, you know, are we waiting too late? Are we not better off, you know, transplanting patients earlier in their course when their livers are not shot, right? You know, the question becomes, should we be cathing Fontan patients regularly and much earlier before they're presenting with any symptoms or any issues? And so, you know, one strategy we have at our center is we do screening catheterizations in our patients. And, you know, we try to do them, we say, once every 10 years, but that may be a little bit too long of an interval. It might be better to do it every 5 years. And if their hemodynamics are off, and you know, then that is a group of patients that we may wish to consider earlier transplantation and just heart transplantation and not wait for the liver to fail. So I think it's still a little bit up in the air as far as what the best strategy is there. But there's no question, I think, once the liver has shown this kind of dysfunction, and as evidenced by a high FALD or VAS score, that you're better off with a liver transplant, in my mind.
Well, Jamil, this has been an incredible session, and there's been so much interest in this. We have about 10 more questions to go, but we don't have any more time left. So what we'll do is, if you don't mind, we'll reach out to you with some of those questions so we can get those back out on social media to answer these really burning questions in this extremely difficult and complex field. On behalf of Houston Methodist and the Adult Congenital Heart Program and the Transplant Program here as well, I want to thank you so much for your and your team's support of our program, and for giving us a wonderful grain rounds today.
Thank you guys so much. Have a great day. Thank you.